So it was very interesting hearing objectives and wish lists from both sides of the House earlier on. Mike Farrer, if I just start with you first of all, what did you take from the first hour that we heard today? Is it a pipe dream? Is it nirvana? Is it just easy to say but hard to do? Or were there positive things that we heard that you think actually that genuinely would make a difference?
I think well, can I start by congratulating the ukactive on existing and also for conferring professorship on me, which I don't have. So I'm assuming I'm now the first.
It's only a matter of time. We actually have it on the QT that it's just
the first appointed professor of ukactive. Thank you very much. I think the issue for all the politicians is that, you know, what would you expect them to say? Well, I'd expect them to set a vision. I'd expect them to the kind of things that Anna and Andy were talking about, to say this is really important as a nation, it's of strategic significance, and you know, we can't carry on effectively trying to manage the problems of this country by supply side solutions, rather than getting up at the sort of tackling the demand issues. So I'd expect them to say what they would say. The problem is that there seem to be fewer and fewer levers in Whitehall that you pull nowadays that make things happen on the ground, and I think that's a good thing in many ways, because many of the sort of command and control edicts that we've seen in the past haven't really worked, and I was struck by the questions as much as anything about lots of people asking them what they could do to solve the problems that I think there is a lot of expertise and experience in the room that is very capable of solving those problems, and we perhaps need to take bit more responsibility and tell the politicians what it is that we need more than the rhetoric. So I wasn't unimpressed by them. I thought they said what I would expect them to say, and I'm glad they want to work cross-party. But I think that it's not just the rhetoric anymore. We've got to get mechanisms in place that help us to deliver, and we've got to have that nothing's going to stop us attitude, really.
Okay, well, we'll come directly on to what those things are that people in this room can help practically with in a moment. Let's talk to the other Mike. You are a professor. Good, that's all right then. So, what was your what was your take? What was your take on what both said?
Well, the important thing is that what Mike just referred to as the rhetoric, I think, is fine. What's terribly important, I think, and it compared to when I started in public health more than 35 years ago, there now is an understanding of the importance of physical activity as part of a public health agenda. That wasn't true. When I began, I can remember going along to my then professor at the University of Glasgow, explaining that what I wanted to do was some work with the physical activity department, physical education department at the university. And in a mainstream public health department, it's regarded as completely eccentric. Why would you want to do that? We do smoking. We do blood pressure, we do cancer, we don't do physical activity. That has shifted during my professional life, and it's pleasing. It's shifted so far that it's now part of the political mainstream too. The heart of the problem, though, I think, is while the benefits, both physically, psychologically, emotionally and so on, of getting active are very well understood, there's no doubt, really, about the nature of the scientific benefits that we see. The problem is getting people active and then keeping them active. And that's really the biggie.
If I could ask you to do almost like a 20-second synopsis almost. If you've been involved in public health for 35 years, in the most general of terms, how would you assess public health now compared to in the late 70s?
Well, one, as I've just mentioned, the grasp of the importance of physical activity as part of the deal is not in question. So that's something that's been very important. The other, I think, has been an acknowledgement that of what's called often the problem of health inequalities. That is to say, the damage of things like lack of physical activity and other things are not spread randomly across the population, but they are spread disproportionately among the more disadvantaged. And some of the questions earlier on reflected that. But in order to deal with these differences across the population, you require rather different strategies.
Sure.
And I think it's now the case that that's well understood too.
But in general terms, we are more unhealthy now than we were 35 years ago.
Oh no, there have been big successes on things like smoking, for example. The rates of coronary heart disease have come down. There are a number of things that are going exactly in the right direction. But new problems are emerging, and the big new problems relate to those that are in part linked to physical activity, which of course are obesity, diabetes and things of that kind. So while we've made huge strides in some areas, we've kind of gone backwards in others.
Carolyn, give us your overview on what we've heard so far.
Well, I just thought I must have been invited today because I'm married to a professor. So that's obviously why I'm here. I think one of the things that I heard from Andy Burnham, which really resonated quite strongly, was the issue, and I think it is unreal for people to be overly optimistic about how we tackle this agenda at a time of stringent cuts. And I do think that that is a very fair point that he raised. And for the majority of sports facilities in communities are provided through local authorities, and local authorities are getting the biggest cuts across the whole of the public sector at it's over 30% cuts currently. And the services around sports, active lifestyles, are those which are not protected in statute. And so Andy Burnham made that point, and it's a very relevant point. Nevertheless, the reason why our budgets are unsustainable is because people are ageing and because the social care budgets are completely and totally, the demand for social care is out of control. And therefore, the transfer of public health to local government, I think, presents us with an opportunity where we can really think about the wider issues and how we stop people constantly being cared for at the end of their life for issues which we could have prevented at an earlier point. So I think now is the time that we've really seriously, in local government and central government and in communities, start thinking about how we put resource into preventing people becoming unhealthy.
It's not the key thing, it's not the key point that he was making, and I'm sure people in the room, it would resonate with some of them as well, because they're all involved in different areas, but all related. That if you are in a situation where you're having to make a 30% cut, let's just say, you've got X, and then suddenly, next year, 30% less X, almost the perception by a lot of people, and I'm sure a lot of people who work in sport as well, is the first thing when the meeting convenes, we can cut sport. You can cut sport ahead of transport because people have got to get to places, and then there's education, and do you know what I mean? It's almost the soft option. It's the easy target, and for this great nirvana that Andy Burnham was espousing, it has to actually alter its position in the pecking order.
I'm entirely in agreement with his point that he was making and the point that you're making as well. And that's why I do think the transfer of public health into local government is a real positive, because actually health professionals as well will start looking at the benefits that sport can deliver in the wider agenda. So I do agree with him in that. I think the point that I would make is that local government has very little choice. We now have, the cuts have to take place in a tiny percentage of the services, and actually the biggest cuts in local government have happened in planning and transport and highways as it happens, not in leisure and sport. And the reason for that, in my view, is because sport, leisure facilities are what get people elected. And it's about, I think, what we've really got to do, and the challenge for us all, there are many councils who are transferring leisure assets to community organisations. And I think that's a move that really should be encouraged, because that gets communities protecting the services which are most important to them.
What it should mean in that environment where you're cutting budgets is that you look at the value that you get for every pound you still have. And frankly, one of the opportunities presented by what's an incredibly tough environment for us to provide public services is to be much more forensic about where do we get value. It should point you to spending more money upstream. Now, getting to that place is quite hard, but there are practical things. So we are working hard with local government around spending our money in a more integrated way around social care and supporting elderly and children. But we can work better with local government around spending money on prevention. So there's a transfer of resource across to local government who've got some of the wider determinants of health within their auspice that previously worked in the health service, and the opportunity of getting to health and wellbeing boards early with a business case talking about the return on investment for expenditure is powerful. The other bit, which frankly is a bit of an apology really, I don't often apologise on behalf of my organisation, but we're not a very easy partner for people in this room. So
can I sorry to interrupt, just can you, for there will be people in the room, just explain what the NHS Confederation is?
Well, the NHS Confederation is effectively the trade body for the NHS, so we're a bit like the CBI for industry. We represent 95% of NHS organisations, the commissioning side, the big trust, ambulance services, mental health.
And all the GPs?
Well, not GPs as individuals, but clinical commissioning groups as organisations.
So because several points that were made in those questions was about the unwillingness or maybe the ignorance on the part of some GPs to embrace the kind of ethos that we're talking about today.
Yeah.
Is that something that you discuss and are aware of?
It is, and in fact, in my previous role, I negotiated the current contract for general practitioners. Sorry about that. So when we were looking at quality and outcomes and the evidence base for the kind of things you wanted GPs to do, at the time, back in 2002, the evidence wasn't as strong and we weren't able to negotiate that with the British Medical Association. But I think times have changed and we should be looking again at how do you connect with general practice rather than just their commissioning role. But the point I was trying to make, John, which I think is just worth following up in a little bit second, is that actually we change our deck chairs very quickly. We don't really understand public-private partnerships. The NHS budget is so huge that if you talk about cash flow for a small and medium enterprise, we don't quite get it. And I think there is a big job for me to do with my organisations about trying to be a much more engaging organisation that can connect you without the logistics of the NHS defeating you to a real risk share or gain share arrangement with investment from us and investment for yourselves around this agenda, which is in part about getting better value about how we spend, so we match fund some of our developments in a better way.
Okay, Mike, go on.
Yeah, I'd like to pick up on this question of return on investment, which is actually really, really important. It's important probably more so now as a consequence of the cuts that you were talking about. You have to think about it at two levels. First of all, there's the national return on investment. And if you think about physical activity and sport together, the returns that one gets from that are huge in health terms. First of all, in terms of youngsters, it's fundamental to the development of skills, it's fundamental to the development of bone density, it's fundamental to the development of a healthy child. In the mid-years, and NICE is about to start work on a project we're calling Fit at 50, and that's about the middle years of life, engaging and keeping active during those middle years of life, which have enormously powerful preventive effects on conditions that commonly occur in later life, dementias, vascular dementia particularly, inability to move around and those sorts of things. Taken overall, physical activity and sport provide some of the most powerful preventive measures across the population as a whole. So that's if you think about it, as it were, at national level. At local level, it is possible, actually, Mike, to do these calculations with some precision. So we published on the NICE website a couple of months ago a return on investment tool for tobacco. With that, what you can look at on there is you go to your local authority, or you type in which local authority you're in. It tells you what the population is. It will tell you what the population of smokers are. It will tell you how many are using services, and then allows you to say, what if we did this change to our provision of service, how much would it cost? And second, what could we expect in terms of returns financially and in health terms after a year, after 3 years, after 5 years, after 10 years? And of course, in many public health investments, the benefits, the return on investments come over a long, long period of time. That's the tobacco one. You can look and see how it works on the website today. But we're going ahead now to do one on physical activity and one on alcohol, which I hope will publish early in the new financial year, in other words, April, May time next year, which will allow you to do exactly the same thing with respect to physical activity. And what that allows each individual authority to work out where they might make those investments, in what sorts of things, with respect to what kind of levels of activity and so on. And we think that's quite a useful way of marrying the big picture with a rather more localised picture.
And the place where those discussions should take place are the new to be formed as of next year health and wellbeing boards, exactly. Where, and coming back to the issue about whether doctors get it, GPs get it or not, they will be sitting alongside counsellors and other people from the local community actually commissioning what health services there are. One of my pleas to everybody engaged in their local community is that they are called health and well-being boards, and it would be really good if people did concentrate on the well-being as much as they concentrate on the health, because otherwise it will all be about immunisation, it will all be about the acute services that are provided as opposed to the well-being and the prevention of problems that we've just been talking about.
I don't want to make this all about money, but by and large things often are. And I'll throw this open to the floor in just a second, so if you've got any questions, and please have them standing by. But I mean, Carolyn, it's all very well somebody saying to you, yeah, but if you spend a little bit of money now on health provision, you'll reap the rewards in the future because you'll save so much money. But you will then say, I'm sure, yeah, but I can't afford to look 10, 20 years ahead. I have to look at the now, and that's why that doesn't happen. Is that?
So tackling precisely at that point, we have been working with colleagues in health and in central government and local government in 4 parts of the country to look precisely at how investment, what savings, investment up front would actually deliver in the longer term. And that's particularly around adult social care costs, but it comes into the wider arena as well. And those 4 pilots have just published their results, and they are showing millions and millions and probably nationally billions of pounds worth of saving. So the real challenge to government at the moment is how do you make that switch from one part of the system to another part of the system, and how do you make that in times of plenty you could double fund for a couple of years. At times like now there has got to be that switch, and so the solutions are there. We've all got to put our minds together and get off our territorial areas to make sure that we make the switch going forward.
But I think one of the things, I mean, I'm a big believer in sort of spending the money more collectively, but there are 2 aspects of where I think this industry has got a role to play. One, which is the preventive agenda, i.e. people staying healthy because they start from a healthy position because they have more active lifestyles. And, you know, clearly there is a payback over time on that. But we shouldn't forget that for a lot of people with known, defined, diagnosed chronic disease or problems, actually keeping active will avoid costs in a much shorter time period. The trick for us is where does the money go in and where does it come out, and how do you arrange the beneficiaries of those to be able to support those people who invest. And that does come back to this point, particularly when we have a public-private partnership, as we might with the NHS and people in this room. A lot of it, it's about how can we get resources to invest with you and then get the profit share, the gain share arrangements to put back in the system, because that's bedeviled us in the past.
Well, listen, you're all involved in public health to a greater or lesser extent. Any points that gentleman in the front wants to pick up on, any of the issues we've raised so far, and then we can take it elsewhere if you want to. Yes, got a microphone, and then I'll come to you, lady. Actually, go to the lady first, and then I'll come to you second. Yeah.
I'll stand up. Nicola Curran from Evolve Leisure. I'm a training provider delivering qualifications like exercise referrals. Just want to bring up the point on value. My perception has been that if you're going to quantify it, signposting people to free swimming, free gym memberships, you're not addressing the point of behavioural change, which is why these kind of initiatives probably haven't worked so well. If someone is obese, they do understand that they need to be physically active. So just by kind of giving them a carrot of free swimming or a free gym membership is not going to cut it. So what kind of infrastructure can we put into place to handhold them through that process until they've made substantial behavioural changes?
What would you do?
Well, actually, when David spoke about one of the initiatives in Essex, I managed about 500 patients that were referred to us, and we had more of a structured educational group feel to it. We put our lifestyle advisors into GP surgeries. So these patients were referred and handheld all the way through the process. We educated them on reading food labelling and all of that kind of thing, but it was more of a group focus. So we walked them through the process, hugely successful. We showed that we reduced the foot through GP surgeries, cut on government spending on NHS costs, inpatient, outpatient costs. But then with the change of government, the whole system was cut almost overnight. It was left with 500 patients with nothing. So the question is, the point is, I don't think free this or free that works. Great, but it's more about the behavioural change. And my question is, how do we address that?
Okay, who wants to answer that? Mike.
Yeah, it's a really good point that you're picking up on. And I think, first of all, we actually know a great deal about behaviour change. and how to sustain it and what to do. In fact, what Caroline didn't mention, not only is your husband a professor, but your sister-in-law is also a professor, Susan Mickey, who's one of Britain's leading professors of behaviour change. And she and other colleagues have worked, we've got really good centres here in Great Britain on this. Now, essentially, without going into too much detail, you have to distinguish between that which is initially the prompt to do the behaviour, and something that's free might be a specific incentive to do that, as against what I called a moment ago, the sustained nature of the behaviour change, when it becomes habitual. Now, habit forming is made up of two elements, actually. On the one hand, there are those bits of all of our psyches which responds to the rational side of our thinking. We know that exercise is good. As you just said, someone who's obese knows they need to take more exercise and eat fewer calories. It's doing it and keep doing it that's the nature of the problem. So simply having that information, appealing to the rational side of what people feel and do, is only part of the story. The other part of the story is that part of us that responds to the immediate environmental cues, the things which nudge us, if you like, to do particular kinds of behaviours. I never got close to the tea trolley at the break, but, you know, I'm pretty sure if there'd been some nice-looking cake or biscuits there, I'd have probably thought, I really shouldn't have it, but it's there, I will. It won't do me that much harm because I'm going rowing on Saturday morning anyway, I'll be okay. Now, all sorts of behaviours are driven by immediate environmental cues. So one of the things we need to think about in a much more systematic way than we ever do socially is keeping the cues going in the right direction for the kinds of things that keep us active, rather than the sorts of cues that make us inactive. The building I work in is a fantastic example of keeping you inactive. You walk in there, try and find the staircase if you want to climb the stairs, and you have to be a kind of equivalent of a Ranulph Fiennes explorer to actually get to the staircase. It's so well hidden by the architects. The obvious solution is to use the lift. Now, so long as we don't have the kind of integrated thinking that puts that in front of us, the things that make it easy to be active, then we're going to make it. We won't get very far in this endeavour. But what I think, just to go back to where I started, which is that there is a science of behaviour change. The problem has been we don't implement it. We don't use what we know, and instead we get to these simple-minded solutions which do not, on the whole, deliver the kind of things that we need to happen.
I may have mentioned this last year, actually, when I hosted this, in which case I apologise for repeating myself, but when I actually hosted the Peugeot National Sales Conference in Coventry about 10 years or so ago, and the head of Peugeot came over from France, the big boss of Peugeot came over from France, and he was a fitness nut, and he had changed the entire working practice of the whole of Peugeot. They may have gone back to whatever was since then, but he actually changed the entire working hours of Peugeot so that nothing happened until 10 o'clock in the morning. His reasoning for that would being, I have given you the time to go for a run, to go for a swim, to go to the gym. Therefore, effectively, I'm not expecting you to knock off early because you've got to get to the gym. I've given you an hour, 2 hours, 2.5 hours, 30 minutes, however long you need to get some exercise, to get you mentally sharp, because I think you're going to work better if you come in at 10 o'clock in the morning and actually you've done your physical activity and you're raring to go, rather than if you come in at 8 o'clock in the morning, having not had any activity and yearning, if you like, during the course of the day to actually get some activity done later on, which I thought was so clever. And I wasn't aware of various things I've done subsequently. I'm not aware of any other company that's actually followed that. You might say that practically, financially, it doesn't work. His argument was that actually, financially, it made sense because he got much more out of his workforce because they'd already taken some exercise and they were more mentally alert for the rest of the day than they would have been if they hadn't. Anyway, that's going off at a tangent. Gentleman in the front, yeah.
Thank you. Gabriel Skelly, Professor of Public Health and Planning at the University of the West of England. And I think Mike's answer about the cues is really what I'd like to touch on. One of the things Andy Burnham said was to prioritise cycling and walking over cars. I mean, a really good cue, for example, for the NHS would be to change their travel expenses regime so that they don't reward people for using cars, because the bigger your car is, the more money you get in your travelling expenses and so on. And it's been really very difficult to get the NHS managers to change this. And why can't that change? Because there's a real difficulty, I think, in people saying nice things and organisations saying nice things.
That's the danger of the whole of today, that we all say nice things.
Never doing anything about it. So there's a good example of getting the cues right. I mean, and Karen, local government, I think public health is really looking forward to being back in local government, where it all started, way back in 1848. And that is great. And there was a talk about investment and where money can be got from. Tobacco industry receives... local government is a major shareholder in the tobacco industry. The local government pension funds have about £1 million invested in the tobacco industry, which will be an interesting test of their statutory duty to improve health, I think. But there's £1 million that could be invested better and invested in ways perhaps to help people.
So the question you want is what? What do you want them to...
Two things. There's queues coming from NHS in terms of their travelling expenses, stopping people being active. And secondly, there's the money sitting in local government that could be invested in better things for health.
Two questions. Mike?
I think Gabriel's made some strong points, but actually I want to link the two, which is the opportunity of the workplace. So, John, your comments about Peugeot, I don't think are left field at all. I was appointed about 2 years ago, I think, by Andy Byrne, when I was Secretary of State, as the National Tsar for Sport and Health. I was appointed the same as Arlene Phillips became the National Tsar for Dance and Health, so you could see how seriously I was ranking with the cancer and the heart disease Tsars and things. But anyway, one of the things that we did to try and get traction was we went into the NHS workplace with the largest employer in the country, great opportunity to do things, and we found no shortage of uptake in terms of NHS organisations wanted to provide stuff for their staff as part of the working day, and this was critical. Our challenge was not to facilitate and promote more activity outside of work. It was to offer those opportunities in the working day. So more opportunity to walk, cycle to work, take time off your working day rather than before the working day to actually compete in things like netball and touch rugby and things that have been big successes. What we found was huge productivity gain, better relationships, better commitment to the values of the service, and more people involved. And I think we shouldn't underestimate the platform that employers potentially give us, rather than assuming that all that big block of time during the day is cancelled out and it's not available for people to stay active. So I think I don't want to lose that point. I do think there's a mindset issue in senior NHS leaders. This has not been signalled as the importance, say, of waiting times for treatment, but it's profoundly got to change, because we can't keep on just throwing the money at that end of the spectrum. We have to pull it earlier, and it does rely on some leaders being bold.
Okay, gentleman in the corner.
Hi, my name's Nick Hume, and I'm from Premier Sport, and I was the ex-director of British Water Polo. Just going on to the behaviour cues, and thinking about what, John, you said at the beginning about the legacy of this year of sport. I was quite disappointed in Anna's presentation in that she didn't once mention anything to do with inspiration or role models, and that there seems to be a disconnect between those Olympians, and I know we'll have some later, about their achievements and being in the public domain and really being sort of inspirational characters, with her initiatives on health, and there doesn't seem to be any marrying up between those two, and there certainly doesn't seem to be any clear objectives about how those two are going to be achieved to get the sport, the country active.
Mike Kelly, do you think there's any link between inspirational achievement amongst elite sports people and generic public health?
Oh, yes. But I think the problem is it's not a direct one. It's a rather more diffuse thing. I think inspiration can come in many forms. The super performance of elite athletes as good role models, I think, can be a wonderful example for youngsters. And the stories we were hearing before the break about clubs unable to take that influx of people driven by the success of the games is an opportunity lost, without a doubt. On the other hand, inspiration comes at many levels, and you can have inspirational teachers, inspirational sports instructors, inspirational general practitioners. I think we can use the notion of inspiration, but we ought to remember that all of us here in this room, if we're connected in some way with directly influencing youngsters and not so young people, have that possibility and that potential to lead by example and to be the role model that others wish to copy.
Oh, sorry, a gentleman at the back, yeah.
Thanks, John. Duncan Wood-Allen, cyclist, dodging cars, hockey coach and leisure consultant. Coming back to mindset shifts, through my work and my experience working with young people, I can see two major shifts. One we've talked about already, which is the NHS, and you know, I'm aware that you're working hard on that. but there is huge resistance. And my big concern at the moment is that directors of public health, if they're in post, still haven't got the power within their organisations to start initiating change at a local level, and in effect everybody's reverting back to type. And then the second mindset shift is one I think that we can all influence within this room, and I think it's great that ukactive have rebranded and that they're picking this up and driving with it. But at the moment we've been chasing the same 20% of the population and trying to provide services for them, and they would have kept fit anyway. So we've gone for the low-hanging fruit traditionally. And as a sector, if we're going to be credible with government and actually start to justify additional funding from people like the NHS and adult and social care, we need to fundamentally change the way we work, the way we program our activities, the way we research needs of populations that quite frankly have never set foot in any of our fixed facilities or ever engaged with us outside of them. And so, I welcome where we are, but to a degree I feel maybe we've got to be a lot stronger with our own message internally as a sector. My strapline is, it's the inactive stupid. That's got to be our focus, and I'd welcome your views.
Well, as somebody involved in it, what do you do? It's all very well saying we've got 20, we go for the 20% and that's fine. Do you do anything to try and get the other 80% or not?
Absolutely. I'm involved in building capacity within the leisure operator market around being much more aligned with health and well-being and adult and social care requirements, so that we're starting to shift the provision of, say, bog standard gyms that only attract middle-class males to start being able to meet the needs of a much broader population, and actually to take those skills and capabilities, adapt them, and actually get them into care homes, get them into primary schools, get them out into open spaces.
Okay. Is there one more question on the floor? Because, there's loads more questions. If you're going to make points, if we can literally, with the microphones, whiz round, because Caroline's got to go, and we've also got to bring another speaker on. So, just when the microphone gets to you, if you could be very brief and succinct and to the point, that'd be much appreciated. Lady at the back, please, first of all. Lady at the back with her hand up. Thank you very much. And I'll come to you next. Yeah.
Thank you. Becky Lang from Tommy's, the baby charity. Just wanted to pick up on a few points from the previous speaker and some of the others around behaviour change and opportunities also within the life course. We're desperate to see more pregnant women active. Women tend to find it as a time to put their feet up and relax, when actually it has a significant impact on pregnancy outcome. So I just wanted to ask the panel and anyone else in the room, don't forget the pregnant women, and also around inspiring women and young girls to be more active before they even get to that stage.
Okay, listen, we'll come to final points from the panel in just a second. Point in the middle, yes, sir.
Yes, Paul Martin from Fresh Air Fitness. As I understand it, with the changes that are taking place with the health and wellbeing boards, they do have a duty to provide, to invest in preventative healthcare. But as I understand it, mostly that understanding towards preventative healthcare revolves around reduction of smoking, reduction of teenage pregnancies, reduction of drug abuse. Is there an understanding that actually physical activity is a preventative medicine that they should be investing in?
Okay, we'll come to that in a second as well. Last couple. Gentleman there, then we're done, I'm afraid. Yeah.
Hi, Tim Scott from Asda. Simple question, really. One of the things that I think not really been touched on is, what is the role of volunteers from all the different organisations within UK Active and the sector? How can they play a role in supporting all the things you've just been talking about, like working with GP surgeries, etc.? What do you think volunteers can bring to the mix?
Okay, it's been the year for volunteers, hasn't it? And last point here, where's the microphone gone? Yeah, gentleman here.
Ian O'Hare from Sanofi, a pharmaceutical business. Within our own company, we do see the benefits of exercise, and we do look to actually roll out campaigns on this. What I'm interested to know is this integrated approach at government level, and particularly at NICE, how many drugs are actually approved there with the condition that exercise must also follow that prescription?
Well, okay, that's a pretty wide-ranging topic of topics that everybody's raised there. Caroline, first of all, I mean, the several points were aimed at local authorities there. Just offer us, if you like, a general resume of some of the points that were raised just then.
We'll do 3 points in particular. Is sport seen by health and wellbeing boards as being part of the prevention agenda? Absolutely. And the things which have been done in the past have been done precisely because of top-down government targets, and this presents the opportunity for local communities to determine what is the best course of action in relation to prevention. Public health directors, they do have power. They've got considerable power in their new roles. They've got clear reporting lines and accountability to their chief executive and to members. As an ex-chief executive of a large council myself, this is certainly an issue which I would be prioritising, and I don't meet many chief executives that would not be prioritising this agenda going forward. If they don't use that power, that's a different matter altogether, but they do have power. And finally, on volunteers, the whole issue of the transfer of assets which are currently with councils into their local communities is one that it's an opportunity now, because of the financial situation in which we find ourselves, for people to grasp. And that's an opportunity where volunteers can really, really push the agenda going forward.
Sorry, who is the catalyst for these volunteers?
The volunteers are there. The organisations exist at the moment. The catalyst is the transfer of the asset that belongs currently to the council to the community, for the volunteers to take control of that asset. Okay.
Mike Farrer?
Yeah, just a couple of points in response and in closing, really. One is, I think a number of questions have been about the suitability and the target market. About 25 years ago, the NHS tried, and it's still trying, and not always succeeding, but we try very hard, to change the power dynamic. We talked about a patient-centred service rather than a professional-delivered service, and we've been trying to orientate that, recognising individual need. I think there's something of that transformation needs to take place around the sport and physical activity industry to be centred on the needs of users. I happen to be the Vice Chair of Sports England, and we've seen, with using the resources of national governing bodies who've struggled on participation targets, that far too often there was a traditional offer, and it wasn't easy for people to access, and particularly younger people wanted a different form of their game that could be played quicker, faster, more informally set up. And so I think there is an issue about, can we change the offer, particularly I think for that group that Mike and I would say gives you the most health benefit. The traditional service offer, the traditional sports offer, very often is too difficult an ask for them if they've been inactive. So that's one very quick point. Secondly, Caroline's absolutely right. Health and wellbeing boards that don't even become statutory till next April. No passes have been sold. We've massively got to get a case to them for why physical activity is a really important thing for community wellbeing, community harmony and health benefit. Last point is, I'm involved in the health service in various ways in that role, and we're setting up a National Centre of Excellence for Sports and Exercise Medicine, where we'll do some learning and promulgating the ideas on behaviour change. We've got the NHS Challenge. If I can help you in any way, be a conduit into the local health service, we're a difficult partner because we change the deck chairs so often, but please do use myself. Sue Henry's here as well today, who works for me on this, through the Confederation. Any help to engage the health service. The health service is the biggest beneficiary of the work that you do. We should be a better partner for you to help us. So I'm prepared to help anybody I can.
I think you're realising that you are all parts of a massive big jigsaw, but they all have to work together. Mike, last word to you.
The notion, your point there, John, about we're all part of a jigsaw is absolutely important. The problem that we're dealing with here belongs to us all. As long as we think it's someone else's responsibility to sort out, we won't make any progress. Once we grasp the nettle that it's our problem, it's the health services problem, it's local government's problem, it's the industry's problem, it's us as practitioners' problem, then our chances of moving this forward are greatly enhanced. But to help you on the way, NICE is always there to provide guidance. And several of the things that people asked in that last session, there is existing NICE guidance already. There's NICE guidance on managing physical activity and promoting physical activity in the workplace, for example. The person who asked about physical activity in pregnancy, there's guidance on that, the safe levels of activity, avoiding putting on too much weight during pregnancy. There's guidance on that. And we've also started this year to produce a series of local government public health briefings. And the first tranche was one on physical activity and what local authorities can do to bring this whole thing forward in the way that is desirable. So I think there's a platform to build on. I think we have to grasp the nettle of it being our responsibility, and I think we've got the tools in which to do it. And I can only commend what we've seen today, the launch, because I see that as an important a really, really important development on this landscape.
Thank you to the two mics, one a professor, one not. Thank you very much, guys. And we were going to move on rapidly. We'll let you vacate the stage, guys, but thank you very much. Do applaud, do applaud.